Good day, everyone. Greetings from Hong Kong. This is Michael Wong, Clinical Professor, Department of Psychiatry, Lee Ka-shing Faculty of Medicine, the University of Hong Kong. The topic of my presentation of this lecture is Youth Neuropsychiatry as a New Clinical and Research Paradigm, Implications for Psychopathology and Values-Based Practice. I will follow this outline. First, the challenge of youth mental health for neuropsychiatry. Second, neurodevelopment and interplay with socio-cultural factors in youth. Third, recent experience of a demand for youth neuropsychiatry in Hong Kong. And finally, case study, a values-based analysis of youth psychopathology. Youth, that is 15 to 24 years of age, is the predominant onset period of mental illness, with up to 75% of mental and substance use disorders emerging before the age of 25 years of age. There are dramatic physical and behavioral changes during this critical period. And the transition from childhood to adulthood, especially the critical period of adolescence, that is from 10 to 19 years of age, involves a profound reorganization of both architecture and functionality of large-scale brain networks as reviewed by longitudinal brain imaging studies. This diagram shows the emergence and peaking of different mental disorders during adolescence. ADHD, conduct disorder, anxiety disorder, mood disorders, schizophrenia, substance abuse disorders, and others. We need to know that 1 in 5 adolescents have a mental illness that will persist into adulthood. Here is a section of a newspaper clip from Hong Kong recently. It shows the increase of suicide rate in primary and secondary school students in Hong Kong from 2013 to 2020. What happened is that during the past couple of years, when there were social events and COVID-19 outbreak, we observed a peaking of suicides in youth up to 23 this year over the past 7 years. And if we look at data from our health department, during the year 19 to 20, we have up to 40,000 youth under 18 receiving treatment. And this rate is 6.4% more and 15% more than the figure in 18-19 to 17-18. And just within the year 19 to 20, we have 1,070 new cases. And the reporters argue that this increase has a lot to do with social events and the social restriction related to COVID-19. So it is in this context that we developed a youth neuropsychiatry program in Hong Kong. We reckon a youth neuropsychiatry program has the potential to contribute to youth mental health by focusing on various illness conditions encountered during adolescence and early adulthood, and in particular from a neurodevelopmental perspective. And that includes genetic vulnerability, environmental stress, brain plasticity, and sensitivity periods. And this approach is based on the data from researchers on the complex interplay of various variables identified through basic, clinical, and population neurosciences. This is a very busy slide and diagram. What I want to show is two things. First is actually the dynamic interplay between preclinical and clinical studies. Models, your mental hypothesis interact with actual clinical observations through epidemiology, staging, ecological momentary assessment, clinical trials of different new treatments and interventions will bring us a better understanding of the multi-level interaction between psychopathology, neuropsychology, social functioning and behavior as a real-life issue with those data that can inform us in our clinical practice from genetics, molecular and cellular biology, neural network circuitry and function data through EEG and various neuroimaging. And altogether, we hope to find biomarkers to inform diagnosis and monitoring, as well as mechanisms of pathophysiology that help us to develop therapeutic targets. So at the group level, differences related to psychopathology in youth are observed in the brain, the gray and white matter volumes, rates of change, and interconnectors between different brain regions. In the postnatal brain development, the maximum density of gray matter is reached first in the primary sensory cortex, followed by the prefrontal cortex, which mature much later. As for the subcortical brain areas, especially the limbic system and the reward system, develop earlier. So in a sense, there is an imbalance during adolescence between the more mature subcortical areas and less mature prefrontal areas. This is how it looks like with color-coded neural brain imaging data. The bluish color demonstrates a high level of maturity. So if we look at the cortical areas, that is the surface of the brain, we notice from 5 to 20 it mature bit by bit. So based on an ongoing longitudinal pediatric neuroimaging study conducted by the child psychiatry branch of the NIMH since 1989, we find certain developmental trajectories of structural MRI brain measures. And they look at both healthy subjects and those with ADHD and childhood onset schizophrenia. What they observe is actually across ages 5 to 25, in both healthy and clinical populations, white matter volumes increase and gray matter volumes follow an inverted U trajectory with peak size occurring at different times in different regions. It will give us a better idea. So this is the time, this is change in the brain development. This is what we call the inverted U development. So this is the prefrontal cortex, parietal cortex, central motor cortex. These mature with the peak at around 4 to 6 years of age, while the prefrontal cortex mature later and peaking at around 8 to 10 years of age. So it's just this high plasticity of adolescent brain that permits environmental influences to exert particular strong effects on this cortical circuitry. And it is through white matter maturation, which are the nerve fibers, connectivity, gray matter reduction, those are nerve cells. Those which are not of relevance and being used will treat, and synaptic pruning, again, just like tree pruning, what we end up will be a network that gives an optimal adaptation to the environment. So while this change makes intellectual and emotional development possible, it actually also opens the doors to potential harmful influences. And this may account for typical adolescent behavior patterns that we are quite familiar with, including risk-taking. According to a German study, 62% of all deaths among persons aged 15 to 20 are due to traumatic injuries. So although most youth actually successfully navigate this transition from dependence on caregiver to being a self-sufficient member of society, there's actually also a period of increasing incidence of several causes of psychiatric illness, especially psychosis, mood disorder, and substance abuse. And the pathophysiology of this disorder is increasingly understood as arising from aberration in the maturational changes that normally occur in adolescent brain. So one key observation is actually the highly replicated pattern of typical age of onset for different causes of mental disorder. So what does that mean? I think this suggests that these epidemiological patterns might be the result of periods of development when certain processes are highly plastic and more sensitive to environmental input, i.e., we have sensitive periods in our development. So one way to review mechanisms associated with the characteristic forms of vulnerability during each life phase, I think, is to understand the particular adaptive goals of each stage of development. For example, puberty appears to be a salient example of a developmental process associated with a sensitive period for social learning, as well as the emergence of a range of mental disorder that are particularly associated with social cognitive symptoms. So while neurodevelopmental during youth is a period of vulnerability for the development of major mental health disorder, this actual transition from mental health to illness is highly influenced, not just neurobiologically, but also social and cultural contexts as well. So the way these contexts interact with individual differences, such as genetic variation, to generate or moderate pathophysiology is rather complex. And I will argue that such contextual interactions are likely to be nonlinear, bidirectional, and potentially age-sensitive, requiring a multi-level modeling. To this end goal, the most significant factors that contribute to the onset of mental illness in youth. So we've got a few projects ongoing, and one of these projects called YES, Youth Epidemiological Project. And my colleagues, Stephanie Wong and her team, has kindly allowed me to share this data with you. It's about smartphone use and mental health. So I'll mention some of the basic demographic, the CIASR rating scale for smartphone use. 64 is the cutoff point between low use and high use. And her team correlate the level of usage with different scales, including one for mindfulness and other for symptoms which you are quite familiar with, PHQ-9, JT7, DAS, K6, SDS. So the analysis is still ongoing, so this can only be seen as preliminary. So the average age of the sample is about 20 years of age. The gender difference is about 64 female to male, and the average mean of usage is 61, standard deviation 12, so it's kind of high-ish, kind of borderline between low and high rate use. And so comparing to low rate to high rate, so it's about 64. So in terms of age difference between the low level user and the high level users, no significant difference at all. But in the high use group, surprisingly, actually, there are more females than male. It's a 6-to-4 ratio again. So this is how it looks in a bar chart. So more female than male in the high level use. An interesting correlation between level of usage and mindfulness and other symptoms kind of scores. And the strongest correlation is actually between the level of smartphone use and mindfulness in an inverse manner, meaning that if you are a more mindful person, you tend not to use that much smartphone. So it may support the argument that smartphone addiction may have something to do with mindfulness, and we ask you the question, can mindfulness practice deliver life? Smartphone can be a way to deal with smartphone overuse and protect the developing brain from the impact of this digital exposure. So this is an example how youth neuropsychiatry may research into youth mental health. So let me tell you more about our neuropsychiatry program. So this is the first kind of its kind in Hong Kong after a return to China. It's a tertiary specialist program that serves the whole territory. With a population about 7 million, it takes referrals from specialist psychiatric, medical, and surgical programs. In Hong Kong, there's a high level of stigma towards mental illness, as in many other places in the world. And if a person suffer not only mental health problem, but also medical and surgical disease, the stigmatization is actually double, what I call doubly stigmatized. So that's why a patient with both physical and mental problem probably even more unforthcoming in regard to help seeking. Although in most public general hospitals in Hong Kong, we have a very good consultation needs on psychiatry, dealing with referrals from any other specialties during inpatient stay. But usually, because of limited resources, we only offer one-off assessment of acute behavioral disturbances or delirium, and further assessment or follow-up post-discharge is actually very restricted and limited. So our program exactly has been developed to address this service need and gap, focusing on clinical presentation at the different interface between psychiatry, neurology, and general medicine, and not only looking at localized brain lesions, lab findings, or disorder distributed brain network, but we also, because of our psychiatric expertise, look at the impact on social relationship and environmental or ecological adaptation. So the service commenced in 2019, and for the first 2 years, we've got 52 patients. And so out of this 50 patients, 25 of them actually female, with anxiety and depression associated with perimenopausal hormonal changes. Some of them have cognitive disorder secondary to the vascular events related to encephalitis or rupture AV, fistula, or stroke in the brain. And 5 of these 52 have movement disorder. Some of them are related to antipsychotic induced kind of dyskinesia, paresis, weakness, or functional neurological disorder, or previously known as conversion disorder, or further back, hysteria. 3 of these 52 patients have atypical presentation of psychosis. They were initially thought of having just a head consumption or dysmenorrhea or even poorly controlled diabetes, but our assessment find out they were actually psychotic. One actually had epilepsy or temporal lobe epilepsy, popularly known as compressed partial seizures. One had dissociative state, initially or wrongly diagnosed as epilepsy. One has a very interesting congenital disorder, absence of corpus callosum. This is the major white fiber link between left and right brain. He didn't have it. He doesn't have it. And he will refer us because he committed arson, setting fire. And one had a autoimmune psychosis, anti-MDA, and 2 patients had very complicated and treatment non-responding psychosis, require very detailed and expert titration and fine-tuning of medications. So this is more or less a typical profile of patients that one sees in neuropsychiatry. But between July and 19 and the beginning of 20, there was a surge of youth referrals to our program. And what happened? So that happened to be the period when a significant number of Hong Kong youth was involved in mass street protests. Many youth in Hong Kong at the time were concerned about the changes of socio-political condition in Hong Kong. More recently or now, while there was a reduction in social events that disrupt law and order, the COVID-19 outbreak, continued to make our youth feel that we are experiencing a loss of freedom and choice in life and in career in general. Not to mention the very common sense that parental expectation and demands are kind of a top-down control on them, suffocating their creative and innovative exploration. A very common kind of feelings among youth in Hong Kong nowadays. So I want you to share with you quickly the first 4 youth who referred during this period of time. And they all reported that study, work, family, and social life have been affected by these 2 events, i.e. the social events, the mass street protests, and also the COVID-19 outbreak. So the case events have all been de-identified to ensure confidentiality. So A is an 18-year-old student who makes several impulsive attempts of self-harm, self-cutting, and attempts suicide. She tried to jump off from height at school. She's been subjected to repeated bullying since her secondary school years. She had multiple episodes of staring look, followed by hearing command hallucination to help herself. So mental state examination noted arbitrary hallucinations and delusion of reference and persecution. Her executive functions, capacity from the prefrontal lobe were reduced in speed, but her condition was otherwise normal. So we did a neurological exam, and that was normal. EEG of the brain showed generalized slow waves and multifocal spikes. So MRI brain scan was normal. So her diagnosis was actually compressed partial seizures, epilepsy, and her psychosis was initially ictal and post-ictal, meaning that during seizures and soon after seizure, but later on kind of extended to inter-ictal period. That is even when she was not having seizures. But fortunately, she responded readily to anticonvulsants and also antipsychotic. So apparently she's been unwell for a while, but she did not decompensate until the social events and so COVID-19. So just want to highlight the social cultural aspect of stresses on a brain disorder. So B is an 19-year-old student who was the victim of childhood physical and emotional abuse by her mother, sexual assault by a stranger, and a frequent target of bullying at school. Her mind very often goes numb and blank in class. She got distressed by student protests and start hearing voices and seeing characters in her head, which make her angry and want to cut herself. So neurological examination, cognitive assessment were both normal. EEG and CT brain were normal. So she was diagnosed with dissociative state, and she actually responded to SSRI antidepressant and support from friends from her church youth fellowship through prayer ministry. So again, the social event further complicated her individual traumatic experience, leading to illness. C is the 21-year-old student whose first episode of psychosis was not responding to antipsychotic medications. So, and this is in the background of a past history of fall and head injury resulting in intracranial bleed a while ago when she was 5, and otherwise her development has been fine. But then she developed delusion of reference and persecutions, and this further worsened after she participated in student protests and was distressed by the COVID-19 social restriction. So neurological and examination and cognitive examination are otherwise normal. The MR brain scan did not detect her previous head injury and intracranial bleed. The mental state examination further showed that apart from the psychotic symptoms, she had actually post-traumatic symptoms as well, which with proper specific treatment helped her actually to her psychotic symptoms to respond better to treatment. So D is a 24-year-old administrator, so a slightly older youth, found her first full-time job very stressful, and she had, out of the blue, a sudden onset of tremor chorea, which is a kind of involuntary, jerky type movements and convulsions, just like epilepsy-like seizures. She has otherwise been having a very, very good personal history, healthy, active, capable, sociable. So she was given lots of investigation, lumbar puncture to look like CAT scan brain, EEG, MRI brain scan, heavy metals, autoimmune screening, and all turned out to be negative. And she actually her family was very distressed by the lack of any investigation result and a lack of proper diagnosis. And the neurologist, together with our program, reckon this is likely to be a case of functional neurological disorder, or otherwise known as conversion disorder, and further back in the history of psychiatry, hysteria. So what happened? Why has this otherwise well-adjusted and capable and driven young administrator become unwell? So we reckon it probably is the convergence of stress at the individual level at work, together with the bigger kind of social cultural context in the form of COVID-19 outbreak and the social political upheavals that she went through. So her movement, the involuntary movement, actually fully improved and recovered over a period of 2 months when she actually took time off work and started to take some antidepressant because she started to have depressive symptoms, which became apparent when her movement disorder disappeared. So I hope the about 4 case vignette help you to agree that there's a critical and urgent need to the models of psychopathology, which has a significant onset during the youth period when major neurodevelopment occurs. And I would like to argue that youth neuropsychiatry provides a paradigm that addresses this challenge. So finally, I want to use this case and discuss that through the perspective value-based practice to have a more in-depth understanding of psychopathology. So Yi is a 21-year-old man who does not have a job and does not go to college. Since he was 7 years old, he has been staying at home playing video games. He aspires to become a professional gamer. At the same age, he did not prepare for and did not take the Hong Kong Diploma of Secondary Education exam, which was mandatory if one wants to move on to study in university. And he actually dropped out because of gaming. And he continued to play video games, and most, if not all, of his friends met online through video games. So his routine is like this. He usually wakes up around 11 o'clock in the morning and plays video games until 3 to 4 o'clock on a daily basis. And he seldom leaves the house. This has been going on for 3 to 4 years now. He does not have a good relationship with his parents because they always ask him to stop gaming and to get a job. He insists on playing video games for a living though. And but he did not actually go and seek a related job that will help him to go professional. So his mother tried to cut him off financially in an attempt to encourage him to get a job, but he doesn't care. He just stays at home and continues to play video games. So his situation resembles the hidden youth phenomenon in Hong Kong, also known as the hikikomori in Japan. So hidden youth describe young adults who are in 3 to 6 months or more of self-imposed real-life home isolation, characterized by the avoidance of social and family relationship, although he or she may have relationship online, and occupational and educational disengagement, which E has most of the criteria. And many studies actually show that there's an association between IGD, internet gaming disorder, and the hikikomori symptoms. So he is very impatient and irritable. He also has difficulty with communication, and he rarely meets anyone outside of his house. However, he did not express any depressive symptoms and is generally happy when gaming and when immersed in the video game world. So I will argue that digitalization after industrialization and urbanization is actually affecting norms and values, not only activities of daily living and leisure, but also study and vocation in general, population, and in particular youth. So Yi has an aspiration to become a professional gamer and decides to get out of school to focus on gaming. He has a reverse sleep-wake cycle, avoids social interactions, and rarely leaves the house, totally against the norms and values of the society in Hong Kong for a young adult. However, while he's impatient and irritable, which may be his temperament or personality, he's actually quite happy and does not have any psychopathology that we're familiar with or observed in those 4 patients that I shared with you early on. A matter of concern is that his gaming exposes his developing brain to digital stimuli and may have an impact on his final neurocircuitry, which in turn may have affected how he understands and develops existing values. So this is one hypothesis due to our neuropsychiatric understanding of the vulnerable and neuroplastic brain. So to finish this lecture, I would want to take you through the process of applying value-based practice into understanding and planning of treatment for E. And I will start with 3 questions which we would not have time to answer here, but I would like to invite you to take this back to your class, to your tutorials, to your friends, to have a dialogue or debate. Is E's choice of gaming as a career and ignoring his school education a psychopathology? Is E's choice of a hidden use lifestyle and illness behavior? Can the fact that the use of digital device such as gaming console will affect a developing brain used as a medical argument for a legal ban of underage gaming? Have a go. So I'll here quickly summarize the process of applying values-based practice into the clinical engine of E here. First, mutual respect. That is, to both E's values and his parents' values. Both of them matters and of importance if you are going to get some meaningful and positive clinical outcome. Awareness. As a clinician, we need to acknowledge that I'm aware of their values. Knowledge. That I understand, although not totally, where their values are coming from. Reasoning. That I have listened and kind of followed the line of reasoning for the choice of action and preference so far as discussed in the case vignette just now. Communication. That in order to move things further, I really have to try my best to bring them to the table to talk. About what? I think centering on personal values. We need to be clear that E actually wants to do something that he enjoys and he's good at. And he's arguing that along the way, he will make a living. That seems to be what he really wanted to do. MDT. This therapeutic process that I'm going to design for E cannot be done by myself alone. It has to be through a multidisciplinary team, MDT. So not just medical colleagues, but psychologists, teacher, occupational therapist, social worker, a voluntary organization helper, etc. This values-based practice-informed approach can be seen as two views. In what sense? In the sense that I have to let E and his parents know that evidence-based medicine and value-based practice both highlight some potential tensions, read the pros and cons of gaming on one's mental health through different perspectives. So that is certain convergence there, of concern there. Another helpful approach informed by value-based practice is what we call squeaky wheel, and that is drawing attentions to the fact that things are not quite working out, not only for Yi, but the parents. And we need to acknowledge that something is not quite right. And so we probably need to do things differently for our own benefit. VBP also reminds us to be science-informed. As I mentioned earlier in this lecture, the use of digital devices can or may have an impact on the developing brain, which in turn may have affected Yi's ways to perceive meaning and significance, different from the way his parents perceive. At the end, the management or intervention will only be therapeutic to Yi and his parents if this is a shared decision making. So, fingers crossed, they seem to have responded to my appeal that say, hey, let's try something that works, and at the same time not posing any negative on Yi's mental health, and at the same time you parents think it's durable and as minimal requirement, meaning that at least he has to do something as well, making his aspiration to be a gamer more financially viable. So I hope the above presentations give us some ideas about the implication for psychopathology and value-based medicine from the subdiscipline or specialty of youth neuropsychiatry. In short, recent advances in neuropsychiatry set new lights on brain-mind ecology relationship, that psychopathology can be formulated as disorder of environmental ecological adaptation and not just nothing but the brain disorder. And that youth neuropsychiatry, together with values-based practice, provide a paradigm to explore how social and cultural values impact on their neurodevelopment, youth mental health, mental illness, and their psychopathology. Thank you everyone for your attention. All the best for your study and research. Bye.